Hi, my name is Justin Mitchell and I'm a physician at Rush University Medical Center in the Department of Hepatology. I specialize in treating patients with acute and chronic liver disease as well as liver transplantation. I would like to thank the American Liver Foundation for asking me to speak on a topic I find extremely important, which is preventing viral hepatitis through vaccination. As you're aware, medicine has been mostly a reactive field where we treat patients who have already developed chronic disease. However, I think things are shifting towards a more preventative role, whether it be preventing cancer development through screening procedures, or in this case, preventing viral hepatitis through vaccination. I have no disclosures to make. The objectives of this talk will be to define hepatitis and identify associated viruses, outline who's at risk for developing viral hepatitis and the associated complications, discuss vaccinations as a disease prevention strategy, as well as outline the importance of vaccination on long-term health and as health maintenance. So what is hepatitis? Hepatitis is basically just inflammation of the liver. So the first part of the word, hepat, is from the Latin root liver, and itis means inflammation. So viral hepatitis, therefore, means a specific virus leading to inflammation in your liver. There are 5 different types of viral hepatitis that we associate with acute and/or chronic liver disease. These can be hepatitis A virus, which is transmitted through a fecal-oral route, hepatitis B virus, which is transmitted through exposure to bodily fluids such as semen or infected blood, hepatitis C virus through exposure to blood, hepatitis D virus, which is an interesting virus as it requires a co-infection with hepatitis B for replication, as well as hepatitis E, which is again through the fecal-oral route. These viruses can cause acute infections and lead to acute liver-related issues. These can be acute hepatitis, which is just elevations in aminotransferase levels or liver enzymes, as well as jaundice, and can be as severe as to cause acute liver injury or acute liver failure, where there is so much inflammation and cell death that the liver is unable to function and create clotting factors and proteins that it's supposed to. This can progress to death at times. Some of these viruses are also known to cause chronic infections and lead to chronic liver disease. When a liver has ongoing chronic inflammation over time, there's activation of fibrosis or scar tissue development as the liver tries to heal itself. Just think of if you develop a cut on your arm or skin and you develop a scar, this is what happens with time in ongoing inflammation in the liver, and this can lead to cirrhosis if you develop enough scar tissue or fibrosis development over time. Chronic infection, as well as leading to cirrhosis of the liver from ongoing scar tissue, also increases the risk of developing liver cancers. In some cases, there does not even need to be the development of cirrhosis, but a chronically inflamed liver can develop liver cancer independently of scar tissue development, period. So vaccines provide an active acquired immunity to a disease. These typically contain an antigen, that is a protein associated with a virus or an inactivated virus, that stimulates an immune response, basically the development of antibodies, so you develop immune memory with time. That is, if you ever are exposed to the virus in the future, your body will recognize it, and your antibodies will clear the virus to prevent infection. So vaccines can be used prophylactically and as prevention of future infections, and in some cases therapeutic as to help treatment of an ongoing virus or tumor. In this talk, we're going to focus mostly on prophylactic vaccination. So the vaccine goals are to reduce the morbidity and mortality associated with acute viral hepatitis infection, as well as to prevent the development of chronic liver disease and liver cancer. So out of those 5 viruses we had mentioned before, we have vaccinations against 2, and those are hepatitis A and hepatitis B. As we had mentioned briefly before, hepatitis D requires co-infection with hepatitis B for its replication life cycle. So this is actually preventable as well with prior vaccination against hepatitis B. So our first virus we have vaccine for is hepatitis A. Like we had mentioned before, this is transmitted through a fecal-oral route. That is ingestion of something, either a food or water source that has been contaminated with feces of an infected person. Outbreaks are common. In the United States, it's mostly through contaminated food. In other endemic areas, it can be seen in contaminated water. The prevalence of hepatitis A is worldwide. Infection rate is much higher in developing countries, as you can see by this graph. Found more often in regions like Asia, Africa, South America. However, it remains one of the most preventable infections that is usually acquired by travelers from the United States. So the incidence of hepatitis A in the United States was as high as 25 to 30,000 cases per year in the mid-1980s. This significantly dropped, as you can see by this graph, after vaccination became available in 1995. And the CDC now estimates that there are approximately 2,000 to 3,000 new cases in the U.S. per year, which is a significant decrease. The hepatitis A vaccination vaccine is composed of an inactivated hepatitis A virus, so there is no risk of developing infection from the vaccine. It is a highly effective vaccine leading to immunity in up to 95% of cases. And the duration of immunity is long-lasting and at times greater than 15, maybe even lifelong. Booster doses are not usually recommended or required. So who should be vaccinated against hepatitis A? So any child after the year of 1 year old should be vaccinated, or other children or adolescents who live in communities with high disease prevalence that haven't been vaccinated. Persons traveling to or working in countries that have intermediate or high rates of infection. People who travel to developing countries are at high risk for development of hepatitis A, and this is even if you travel to urban areas or stay in nice hotels or monitor what you eat. There are reports that per 1,000 visitors per month to developing countries, anywhere from 3 to 20 people out of those 1,000 will develop an acute infection due to hepatitis A, despite some of these precautions that they take. So it is important that these travelers are vaccinated as well. Other people should be men who have sex with men, as there have been frequent and recent outbreaks that have occurred in urban areas, especially in the United States and other developed countries, as well as people who use illegal injection and non-injection drugs. Patients with chronic liver disease should be vaccinated as well, or other people with clotting factor disorders that are administered clotting factor concentrates. So this takes us to our second virus that we have a vaccination for, hepatitis B. As discussed earlier, this is transmitted through contact with infectious blood or bodily fluids. Some examples of this would be sex with an infected partner, injection drug use that involves sharing needles, birth to an infected mother, needle sticks or sharp instrument exposures that might happen in a healthcare setting, as well as sharing razors or toothbrushes in the home situation. Prevalence of chronic hepatitis B is worldwide. Again, it's most prevalent in the developing world, Asia, Africa, South America. Immigration to the United States, we are seeing more and more chronic hepatitis B here, period. In areas of high prevalence, this makes up 45% of the global population. In these areas, there's a lifetime risk of infection that exceeds 60%. And most of the time, these are early childhood infections. In intermediate areas, which makes up approximately 43% of the global population, the lifetime risk is still high, from 20 to 60%, and infections occur in all age groups. In the low prevalence areas, the lifetime risk is less, and many of these infections occur in the adult risk groups. So the clinical outcomes of hepatitis B infection, as we had mentioned before, in the endemic areas, exposure at birth or at childhood is highly prevalent and goes on to chronic infection in a majority of the cases. With the development of chronic infection, it leads to chronic inflammation and hepatitis, which can progress to cirrhosis and the development of decompensation or complications from cirrhosis, development of liver cancer or HCC, which stands for hepatocellular carcinoma, as well as death. You can see that in this graph that if you were exposed to hepatitis B at birth or at an early age, the risk of chronic infection or developing a chronic infection is much higher, and as you progress, if you're exposed as an older child or adult, it is more likely to clear the infection. However, you're more likely to become symptomatic. So vertical transmission, or transmission from the mother to the newborn, is a major problem, especially in endemic areas. In this, the risk of transmission to an infant can be as high as 90% in mothers who have chronic hepatitis B. This is again without post-exposure immunoprophylaxis. So what is prophylaxis? So this is immunization with HBIG or hepatitis B immunoglobulin, as well as a vaccine at birth, and especially within 12 hours of delivery, and this significantly reduces the transmission rates. So the incidence of acute hepatitis B in the United States has significantly decreased since the mid-80s. This is in 1986 when the first recombinant vaccine became available, and decreased even more in 1991 as routine vaccination of all infants was mandated. And this graph demonstrates that as well as acute infections, chronic hepatitis B infections have markedly decreased not only in the United States but across the world. The blue bars represent children who have chronic hepatitis B, and these were born before the vaccine was available. And the red bars then represent children who now have chronic hepatitis B, and you can see the significant decrease in the amount or the number of children with chronic hepatitis B after the vaccine was introduced. So vaccination against hepatitis B is also a cancer prevention technique. Chronic hepatitis B is related to 60 to 90% of adult liver cancers, or HCCs, and almost 100% of childhood liver cancers, especially in endemic areas. The first universal hepatitis B vaccination program was launched in Taiwan, and data from that region 20 years after the launch showed significantly decreased rates of hepatitis B in the general population, as well as significantly decreased rates of liver cancer in children. This data could be extrapolated out that there will be decreased rates of liver cancer development in adults with vaccination as well. So the routine infant hepatitis vaccination or immunizations programs are very important. They decrease the incidence of acute hepatitis B. They decrease the prevalence of chronic hepatitis B infection, as well as the development of cirrhosis, and decrease incidence of hepatocellular carcinoma or liver cancer. The hepatitis B vaccine, the Australian, or later known as the S antigen, was first discovered in 1965. This was later used to form vaccines in the early 80s, and development of the recombinant vaccine in 1986, which is what we use currently, period. Universal infant vaccination went into effect in the United States in 1991, as did universal adolescent vaccination in 1996. The hepatitis B vaccine is extremely efficacious in that it leads to immunity in 95% of cases. It's composed of a component of the virus cell wall known as the surface antigen or surface protein. The immunity is long-lasting, and booster doses are not routinely recommended. So who should be vaccinated? So currently all infants in the United States should receive their first dose of vaccine at birth. Other children and adolescents should be vaccinated if they have not already. Any people with partners with chronic hepatitis B, or sexually active persons not in long-term or mutually monogamous relationships. Men who have sexual contact with other men, as well as individuals who share needles or drug injection equipment, healthcare and public safety workers at risk for exposure to blood or blood-contaminated body fluids, people with end-stage renal disease undergoing hemodialysis or peritoneal dialysis, as well as travelers to moderate to high prevalence areas, and again, people with chronic liver disease or HIV infection. So I'd like to just touch on the idea of immunization in chronic liver disease. Infections with hepatitis A and hepatitis B do occur in patients with other chronic liver disease and or cirrhosis. And there's a substantially higher risk of death in this patient population if they are exposed to these viruses. There's also the idea that as liver disease progresses, immunizations will lose their effectiveness, and so we should try to address immunity needs in our patients with chronic liver disease early. Again, this will help prevent the increased risk of mortality with superimposed hepatitis A or hepatitis B infection on top of a chronic liver disease process. So in conclusion, vaccination is the first-line defense in disease prevention. Early administration offers the best opportunity to prevent disease transmission and reduction. And we should continue our efforts in vaccination and health maintenance. I would like to thank you for joining us today for this talk in preventing viral hepatitis through vaccination. I'd like to thank the American Liver Foundation for giving me the opportunity to speak with you today, as well as the Rush University Medical Center.